And so we'll start with our first case. This is something that you would see pretty commonly, particularly in my environment where I work in a large emergency department with a lot of people who are old, who have a lot of vascular disease. So as you can imagine, older people coming in with abdominal pain, and that's a pretty common problem. And it presents a lot of different things that you might think about, which can be really, really dangerous for the patient. So when this patient comes in, he's brought in by an ambulance, and the EMS people tell you that this patient has actually some low blood pressure and his heart's going kind of fast. He's complaining of not only abdominal pain but back pain. And in terms of his past medical history, you know that he has this hypertension from EMS, but you also find out that he is a smoker, and that he also has a history of diabetes. And when you initially see him, his vital signs show that he's got an elevated heart rate, he's got an elevated respiratory rate, he's got a low blood pressure, and he's got a little bit of a fever. And particularly in what I do in our line of business is this guy has 4 abnormal vital signs, and he's old and got abdominal pain. This guy is potentially really, really sick. And so as you can imagine, we start thinking very quickly about all the things we might need to do to make sure that this guy's going to be okay. So we do a quick physical exam, and we notice pretty much that this guy is speaking clearly, so we know that his neurologic function is probably pretty good. But we can see that he's a little sweaty. We take a quick listen to his lungs, and we notice that they're clear. We feel for a pulse, and although we can feel it, we notice it's a little weak, particularly in the distal extremities. And when we examine his abdomen, we notice it's not tender. There's no tenderness to the abdomen at all, which makes us think that, you know, this guy's complaining of abdominal pain. Why doesn't this hurt? So we're going to have a list of different questions for you. In emergency medicine, we tend to think of things in a lot more simple fashion than what maybe Tommy was doing earlier with you, with what you know, we would consider to be a lot of really sophisticated echo. And so our first question for you is going to be, what do you want to do next? And your choices are to panic, which is actually not such a bad thing. At least it gets your attention. Or would you do an ECG? Would you get a portable chest X-ray? Or would you ultrasound the heart or ultrasound the abdomen? And I guess now we're going to wait for some responses to see what you guys have to say. It's good to see some of you are picking panic. We still got a few more people to vote. And so just taking a quick look at this, most of you actually go for doing an EKG first. A few of you actually did choose panic, which I have total respect for. And then about 20% of you picked do the ultrasound of the heart, and another 20% picked ultrasound of the abdomen. And I don't think there's actually a best right answer here. But what we have to do when we see this patient, of course, is 2 things. We're going to have to resuscitate and diagnose at the same time, because we recognize this guy is unstable. And we also have to do it very, very fast. And that's something you have to do in the emergency department, probably more so than in any other specialty out there. So you've got to think in different ways. You've got to think about management and diagnosing what's wrong with the patient at the same time. So for those of you who chose EKG on that first question, that's exactly probably what would happen to this patient first. In this situation, it did happen first because, particularly in the United States, and I'm sure in a lot of other places where you guys are, everybody is worried about myocardial infarction. It tends to be the #1 killer, particularly in the Western world. So that's the first thing we did with this patient. And when you look at this 12 lead, there's a sinus tachycardia, but there's really not anything else that's too impressive about it. It's a little bit fast, but it's otherwise not particularly abnormal in any other way. And so from there, we would then go to our ultrasound machine. And this is a situation where in emergency medicine, it's very, very helpful to have this technology, because we can actually look at 2 or 3 areas very, very quickly for maybe 30 seconds each and really get a good idea of what's wrong with this patient, and in addition, actually figure out what we need to do to help this patient. And there really is not a technology out there, by even a long shot, there's no technology out there where we can do this and really make a quick decision about what's wrong with the patient and what we need to do with this patient to salvage them or to make them better. So the first question we tend to ask with this is, what's going on with the heart? if somebody's hypotensive and tachycardic, that by definition is shock. And so the first question I want to know is, do I have a normal heart or a normal pump, or do I have an abnormal pump? And we'll go ahead and look at this patient's heart. And as most of you can recognize, this is a parasternal long axis view. And my only question here is, does this guy have a normal pump, or does this guy have an abnormal pump? And I'll let you look at this for a couple more seconds. And then we're just going to ask a very, very simple question here, which is, does this guy have a good heart or a bad heart? And we'll go ahead and let you guys answer that question. We'll see how you do. And so most of you chose the right answer, which is that this patient has a very good heart. There's really nothing that I have to worry about immediately. He has a normal EKG. He's got a normal left ventricular function. I know that with this guy having hypotension, if I need to give him fluid, I can give him fluid. You only have two choices when somebody's in shock when you're in the emergency department. You can either give him fluid or drugs. And I know by looking at this guy's heart that I can give this guy fluid. The next thing I'd like to know about is, what is the patient's intravascular volume? And Tommy looked at some images before, and I think you guys do this probably fairly routinely. This was not something that was done routinely maybe even 5 or 10 years ago, but that's just to look at the inferior vena cava in the long axis or the sagittal plane. And when we do this, we can get an idea of how much fluid is in the patient's intravascular tank, how much is in their vascular system. And so I'm going to orient you here a little bit. The top of the screen is anterior, the bottom of the screen would be posterior. And the orientation marker on the transducer that you're holding is pointing to the patient's head, which is the same as this mark here, the orientation marker. So this is the patient's head, and this is the patient's feet. This is the liver, and these stripes back here actually represent the vertebra. And in the posterior part of the liver runs the inferior vena cava from the feet towards the head as this enters into the right atrium here. And you can see the IVC here. And so, as you might imagine, if you have a very high intravascular volume, this is going to be much more full or wider. If you have a low intravascular volume, it's going to be very flat. And if you have a very high pressure, the IVC will be large, but it'll also be very stiff. It won't be compliant. It won't change with respiration. And so our next question for you is going to be, what do you think of this patient's intravascular volume? Is it high, or is it low, or is it normal? And so most of you are still putting in answers. And it looks like most of you said it was low at 68%, and that is actually correct. The patient's intravascular volume is low. That is a very flat inferior vena cava. That tells you that the central venous pressure is very, very low. And so for the third part of this, we're going to go ahead. We now know two things. We know that the patient has a normal heart, and we also know that the intravascular volume is low. In other words, there's less fluid in the vascular system than we would expect. And so for our next ultrasound, we're going to go ahead and ultrasound the abdomen. So we put the transducer on the patient's abdomen, and this is the picture that we get. And I'm going to go ahead and orient you. So this is anterior, this is posterior, this is cephalad, or the patient's head, and this is the patient's feet, and we see a structure inside the abdomen. I'll let you look at that for a couple more seconds. And then we're going to ask you another question. What do you think that is? Is this a patient with cholecystitis? Does this patient have an infected renal cyst? Is this an abdominal aortic aneurysm? Is it a pancreatic pseudocyst? Or is it small bowel obstruction? Right, a few more people getting ready to vote. And it looks like we're done, and most of you chose the correct answer. This patient has an abdominal aortic aneurysm. And in this particular ultrasound, we have the same viewpoint, but now we've put color flow over this structure. And this is important because sometimes you're not sure what you're looking at. Is it a vascular structure? Is it something else like a renal cyst or cholecystitis? You don't have any blood flow in those structures. And so by putting color on it, you can see if it's a vascular structure or not. And this actually, of course, is a vascular structure. And it is an abdominal aortic aneurysm. And if you go back to the diagram, this is where we place the transducer. If you strip away the abdominal wall and just look where your transducer is placed relative to the intraperitoneal and retroperitoneal structures, you see it's right over the distal aorta. So now comes the question, what do you want to do next? You've got 5 choices here. Do you want to try and figure out where the abdominal aortic aneurysm begins, where it ends? Do you want to find out if it's leaking? Do you want to panic again? Or do you want to take this guy immediately to the operating room? Nobody's choosing panic this time, so you're getting more confident. And we're just about done. And so most of you wanted to know if it's leaking. 50% of you said want to know if it's leaking, and about 40% of you wanted to really actually take this patient right to the operating room. And so this is often the reaction that we've had when we found these problems in the emergency department for the last 30 years. And only in the last 10 years have we been able to figure this out and do something about it that is actually constructive. So let's approach this problem. We know this person has an abdominal aortic aneurysm, and we'd like to be able to give some information to our surgeons. We'd also like to make sure that this is a patient that needs to go to the operating room. There's some simple things we can do here. First, let's look at the aneurysm in a different plane. Let's look at it in the axial plane. So we're going to turn our transducer. We're going to rotate this thing 90 degrees counterclockwise. And just real quickly, everything that we do with ultrasound, when we orient the transducer marker, we're always going to orient to the patient's right or the patient's head. And this is exactly opposite to cardiac. Cardiac ultrasound is the only one where you will point the transducer marker to the patient's left. All other ultrasound, you either point to the patient's right or their head. And so this is a little bit different or backwards from what you're used to. But anyway, let's just think about how we would look at this patient's aorta from looking from an axial view. And this is actually an axial view cutting through the entire aorta in the abdomen. So going from the proximal aorta here down towards the distal aorta and then finally into the iliacs. And you'll notice that this is pretty fast. We're cutting through this pretty fast. So let's just slow it down and take a few cuts of this and see what we can figure out. So this is sort of the proximal or mid-abdominal aorta. And I'm going to orient you again just to make sure you're following me. So this is anterior, this is posterior. This is the patient's right, and this is the patient's left. So this is just like a CT scan. You're standing at the foot of the bed, and the patient's head is behind the screen. And this is the patient's right, and this is the patient's left. This big structure here, this big anechoic structure, is actually the lumbar vertebra. So you can see here that it blocks all the ultrasound signals and creates a shadow. And in addition, you'll see that there are 2 structures here, which could be vascular structures right anterior to the spine. And these are, in fact, the inferior vena cava, which is to the patient's right, and the abdominal aorta, which is to the patient's left. This structure is actually not vascular. This is the gallbladder. You're seeing it in a transverse cut. This structure right here is the superior mesenteric artery, and this is the left renal vein coming from down the kidneys back here. It's going to come all the way across and go into the inferior vena cava. Because you have these structures in here, you know that this is more proximal in the abdominal aorta, and it gives you an idea of the relative size of the aorta at this point. You can look on the screen on the to the sort of the marker on the right and see that this is about 2.5 centimeters, which is not that big. It's not something that you usually get really concerned about. It's large, but it's not so large that it potentially would be a problem in terms of having to be resected. And it does give you a lot of information in terms of what you need to tell your surgeons, because the critical piece here is if the aneurysm involves the renal arteries, that gives a lot of work to the surgeons, because when they take this thing out, they have to clamp the renal arteries, and almost all these patients can survive the surgery. They usually end up dying post-op from renal failure. So this is a real important piece of information. The next image I'm going to show you is actually at the distal aorta, just before the bifurcation. So the orientation's the same. This is this lumbar spine. And this is the aorta. And you can see from the measurement calipers here that it is about 3 centimeters by 4 centimeters. Now, we very often see much bigger abdominal aortic aneurysms. But remember, this patient's sick. It's tachycardia and hypotension and some other things. And so you really have to, even though that this is not huge, certainly not the biggest we ever see, this is big enough to give you concern that this patient might be leaking. And you also see a plaque here, erythematous plaque. This is the last of the cuts we'll look at, and this is the distal aorta, and then planing down into the iliac arteries. And when we plane down into the iliac arteries, we see these two structures on either side of the lumbar vertebra. And so this is a still image just involving the two iliac vessels. And what's concerning here is that these are way too big. Okay, not only are they enlarged, you can see the right iliac artery is about 2 centimeters in size, and this is much larger than normal. But they also have these plaques in here. And this tells you that the dissection and the disease is not only in the distal aorta, but it's also extending down into the iliac vessels. And this means a lot more work for the surgeon if he's going to need to go in and replace this this aorta and these vascular problems in the operating room. A little bit about abdominal aortic aneurysms. There are two different kinds. There's a fusiform and a saccular version. The fusiform is much more common. This is when it sort of gives you this sort of elliptical shape. It's always, of course, in the distal aorta. These are 99% of these cases. And very often, as we saw in this case that we're demonstrating, can extend into the iliac arteries or can extend proximally above where the superior mesenteric artery is. This is where the renal arteries come out. If it involves that, again, this is all important information for the surgeon. This is a longitudinal view of a fusiform aneurysm. And what a lot of you will do immediately, or at least beginners, is when they look at this, they will look right here and say, oh, that aorta is not really that big. But what you're missing is that this is the aneurysm here. This is just the lumen. This is actually plaque on the anterior wall, which it's almost always on the anterior wall of the abdominal aorta. And this part is actually the lumen. So if you just measure the lumen, you may not think it's that big. But when you actually step back and look at it and make the correct measurement interpretation, you'll see it's quite big. This is an axial cut, same patient. This is actually a friend of mine's dad. He found this aneurysm on his father when he was just practicing scanning him one day. And in any event, so here you can see the aneurysm itself, and then again here's the plaque, and then this is the lumen. So you have to be careful when you look at these things and not get fooled by the fact that you have this this plaque here. The other type of aneurysm is a saccular aneurysm. As the name implies, it's a little sac that comes off usually the anterior wall of the lumen of the abdominal aorta. It's almost always a distal structure. And this can be tricky. One, they're rare. I think in the 15, 16 years I've done ultrasound, I've only seen a half a dozen of these. Here's the distal aorta coming down. Here is this big aneurysm or sac coming off. This is the lumen, and this is all plaque. This is another view. This is a sagittal cut again. Here is the aorta coming down, and then suddenly it poofs out right here. And the danger of this is if you're scanning in the axial plane and you're scanning here or more cephalad, you will miss the fact that the guy has an aneurysm. So it's important when you look at these structures to get both a sagittal and axial cut so that you do not miss somebody with a saccular aneurysm. A couple things about measuring abdominal aortic aneurysms. You have to measure it in the transverse plane from the outside wall to the outside wall, or you'll make mistakes and miss. So this is an axial cut of an abdominal aortic aneurysm, and if you measure, and it's always good to measure too much than too little. If you're a little bit under on your measurement, or you don't measure it correctly, and you say it's only 3.5 centimeters when it's 7, that has a totally different prognosis and a totally different management plan. So you always want to measure a little too big. You also want to measure in the axial plane, because if you come at this in the sagittal plane and you're right dead center, you'll get an accurate measurement. But if you're just a little bit off, a centimeter or two, you'll only think it's maybe half that size. You'll say, it's not that big, or it's not even abnormal, and you'll potentially send the patient home and send them to their grave because you just didn't think about doing it in the right plane. What happens when these things bust or they start to leak? There's two places the blood can go. It can go retroperitoneal or intraperitoneal. This is a CT scan of a retroperitoneal bleed from an abdominal aortic aneurysm. This is the spine, of course. Here's a kidney. This is another kidney. This is your abdominal aortic aneurysm, and all of this material here is retroperitoneal blood. The reason I'm showing you a CT scan is ultrasound is terrible for seeing retroperitoneal blood, and should never be used to rule out this particular problem with abdominal aortic aneurysm. The second place it can go, which is a lot less common, is if it goes intraperitoneal. If it leaks into the intraperitoneal cavity, that basically means you've probably got a dead patient. When you have fluid in the abdomen, that means that this person's really, really sick and that you've got to move very quickly, or they'll probably die within a few minutes. This is a huge problem, and usually we never get this picture on somebody who has a leaking abdominal aortic aneurysm because they usually die before they get to the hospital. Just by comparison, I want to show you what a normal view of this looks like. On the previous slide, we were looking at a video what's called Morrison's pouch, which is a potential free space between the liver and the kidney. And this is the interface right here between the kidney and the liver. This is on the right side, of course. And if you have fluid in the intraperitoneal cavity, it will fill into this space, and it'll show up as this black anechoic fluid. And if you see that there, particularly in leaking aneurysm, that is a disaster, and you need to move quickly. All right, what are the advantages of ultrasound for this particular problem? It is the best quick test out there for finding AAAs, and it's extremely sensitive, so it's a great test. It's absolutely the test you got to have at the bedside to take care of these patients and not miss them and make a mistake. It does have some disadvantages as well. As I mentioned, you can't see retroperitoneal bleeding. It's really not as good as CT for judging the proximal and distal extent of these problems, although you can see them with ultrasound. CT is much better. There's a real tendency to underestimate the size, particularly if you're a beginner at doing this. And if you have bowel gas, it can block your view, which is actually in a very small percentage of patients to see the distal aorta, but it will more than likely block the iliac vessels. So again, it's not easy to judge the distal extent. Okay, so now you've got all this information. We're going to go to another question here. And so what do you want to do next with this question? I think this is the last question in this particular case. And do you want to type and cross 6 units of blood? Do you want to type 2 units of O-negative blood and put that to the bedside? Do you want to call the operating room and anesthesia? Do you want to call surgery, or all of the above? And we'll go ahead and open that poll. And we're getting a few more answers. And I think we're done. So almost all of you said all of the above, and that's correct. You want to do all of these things. These patients are dying, and you need to get as many resources as you can to help out this patient. This is an emergency. This is when you call the operating room. And the terrible thing is to call surgery and then say, oh, we got a AAA down here and you need to take care of it. And nobody bothered to call the operating room and anesthesia, because these are difficult cases. And they roll them upstairs to the operating room and everybody's staring at them and going, what the hell is this? A couple more pointers. And I think this may be the last slide in this particular case. But when you get these patients, put them in a resuscitation bay. They're always the patients that show up in like the smallest room in the ED with the most inexperienced nurse. You need to prepare these patients for transport, and be careful about intubating these patients too. Even if they get very sick, sometimes the pain they have from this problem is the only thing that's jacking up their blood pressure. Their sympathetics are firing on overdrive, and you really we've had problems where if you intubate these patients or give them too much pain medication, they immediately will decompensate, become hypotensive, and arrest. And so I think that concludes. Oh, sorry, I got one more slide. I was wrong. 3 clinical settings to think about when patients with this problem. Think about these patients when they come in. If somebody comes in who's old and has abdominal pain and hypertension, this is a no-brainer. You got to ultrasound all these people and look at their aorta. But also think about these stable at-risk patients with these symptoms. If they come in, you really also need to ultrasound their abdomen. So really any elderly patient who comes in with abdominal pain, you really should think about looking at their aorta right off the bat, just to make sure they don't have this problem. But then there's the other piece of this for those of you who maybe have more of a clinic-based practice. How about every elderly patient? The ability to salvage a patient who is found to have this problem when they're not ruptured or leaking is very high. This can add 10 or 15 years of quality life to the patient, as opposed to when they start to leak or rupture, the morbidity and the mortality of this increases exponentially. And so if you can find these patients before they start to have these problems, you can really do a great job of helping with this. And on a personal note, this is actually the exact same thing my grandmother died of. She had it, I guess, for a while, and she ruptured at home and subsequently died in bed at nighttime. And the other great irony is that my grandfather was a physician as well.